Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
So, how do you actually fix a patient's severe, life-disrupting reflux without completely breaking their ability to swallow comfortably? Welcome to this deep dive.
Yeah, that is the ultimate question, isn't it?
It really is. And today we're speaking directly to you, the four gut surgeons, the gastroenterologists, and, the advanced medical professionals who navigate this highly nuanced surgical selection every single day.
We're looking at two heavyweights today, right? The Nissen and the Toupet Fundoplications.
Exactly. We are unpacking the data to help you match the right wrap to the right physiology. But before we get to the actual tissue and technique, just a quick but mandatory reminder.
Right, the legal stuff.
Yeah. The insights we discussed today are strictly for reference and educational purposes. So, always follow your local guidelines and institutional protocols in your actual clinical practice.
Absolutely.
With that out of the way, let's just jump right into the center of this classic surgical dilemma, because you are essentially trying to reconstruct a faulty biological valve without creating a catastrophic outflow obstruction in the process.
Right, and that tension between reflex control and functional swallowing,
Yeah.
I mean, that's the entire ballgame in foregut surgery today.
It really is.
Because the paradigm for how we make that choice in the operating room, it's undergone a pretty massive shift. Historically, the full 360-degree Nissen wrap was just the absolute gold standard across the board.
Just a dogmatic one-size-fits-all approach.
Exactly. I mean, if a patient had GER, they got a Nissen, period.
Yeah.
But real-world clinical outcomes have really forced a significant evolution in our practice.
Yeah, thankfully.
Right. Today, we are no longer asking which wrap is superior in a vacuum. We're asking which architectural construct best matches a specific patient's preoperative motility data, their anatomical defects, and, their unique symptom priorities.
Because achieving a perfectly normalized Demeester score on a post-operative pH test means absolutely nothing if the patient is sitting in your clinic crying because they can't get a piece of chicken down.
Precisely.
Or they are profoundly miserable with gas bloat every single time they eat. So let's systematically break this down. Before we get into the complex preoperative physiology, we need to establish the baseline physical mechanics.
The hardware.
Yeah, let's talk hardware. How do these two wraps actually interact with the lower esophageal sphincter complex?
Well, mechanically, the architectural distinction is pretty straightforward, but the physiologic implications are profound. So with the Nissen Fundoplication, you're creating a complete 360-degree wrap.
Okay.
You fully mobilize the gastric fundus, which usually requires taking down the short gastric vessels to ensure it's completely tension-free.
Right, it has to be tension-free.
Completely. And then you wrap it entirely around the distal esophagus.
Yeah.
Because it forms a complete circle, it creates the most mechanically robust, high-pressure gastroesophageal barrier possible.
So it's effectively recreating the angle of his.
Yes, and providing a very tight mechanical valve.
Okay, and on the other side of the ring, we have the Toupet.
Right, the Toupet Fundoplication. This is a 270-degree posterior partial wrap. You still mobilize the fundus, but you bring it behind the esophagus and anchor it to the crura and the esophageal muscle itself.
Leaving the anterior part completely exposed.
Exactly. And because it lacks that final 90 degrees of anterior coverage, it's just inherently less obstructive.
I see.
I mean, it still augments the high-pressure zone enough to prevent acid exposure in most cases, but it allows the anterior esophageal wall to expand during bolus transit.
Oh, making it fundamentally more forgiving of the patient's native swallow mechanics.
Spot on. It's much more forgiving.
Let's translate those mechanics into a communication tool. Because when you're sitting in the clinic with a patient who's been doing their own research on Google...
Oh, we all know those patients.
Right. And they are demanding the quote-unquote strongest surgery available, even though their motility is terrible. I find the river and dam analogy incredibly useful here.
Oh, I like that one.
Yeah, you can explain the 360-degree Nissen as installing a heavy-duty, high-resistance concrete dam across a river. It completely stops the flood of acid coming back up.
Right.
But because that dam is so impenetrable, the river pushing against it, meaning the esophageal body trying to clear a food bolus, needs to have a very strong current.
Exactly. The patient needs powerful, coordinated peristalsis to overcome the new high-resistance barrier you just built.
Yeah, and that's a highly effective way to frame it for a patient. The Nissen creates a baseline resistance that demands a strong esophageal pump.
To drive a solid bolus through that newly reconstructed high-pressure zone.
Right. But let's look at the actual data driving our decisions, because I want to push back on the dogmatic use of the Nissen for a moment.
Go for it.
The sources and the recent meta-analyses we're reviewing state that both operations provide highly effective long-term reflux control. The rates of recurrent pathological acid exposure are remarkably similar between a well-constructed toupet and a Nissen.
They're very close, yes.
Yeah. So, if a 270-degree toupet works just as well for controlling the chemical burn of acid, and we know it's significantly less obstructive, why are we ever still performing the 360-degree Nissen? I mean, why not just use the functionally safer option for every single patient?
Well, that is the exact debate happening at major foregut conferences right now. It's a great question. The answer really comes down to absolute maximum barrier strength and anatomical durability.
Okay, unpack that a bit.
While the toupet is highly effective, the Nissen undeniably provides the strongest defense against profound regurgitation. So you lean toward the Nissen when you have a patient with massive volume regurgitation, not just chemical acid exposure.
Oh, I see. Volume versus just the chemical burn.
Right. Furthermore, consider a patient with a massive type 3 or type 8 perisophageal hernia.
Yeah, where the whole stomach is basically in the chest.
Exactly. When the anatomical disruption of the hiatus is that severe, many surgeons feel a complete 360-degree wrap provides a superior anatomical anchor within the abdomen.
To basically help prevent herniation recurrence. So it's about matching the aggression of the repair to the aggression of the defect.
That's a great way to put it. The Nissen remains a highly effective, durable surgery. But the critical caveat, the absolute non-negotiable rule of modern foregut surgery, is that you can only proceed with the Nissen if the patient possesses robust esophageal peristalsis.
Right. Zero significant preoperative dysphagia.
And an acceptable clinical tolerance for the higher risks of side effects. If their esophageal current is strong enough, the Nissen is a fantastic option.
But if that pump is weak,
a Nissen can become a functional disaster.
Which transitions us perfectly to the preoperative blueprint. So how do we objectively measure that peristaltic reserve before making the first incision? And let's skip past the basics here.
Yeah, we don't need to rehash diagnosing GERD.
Right. We all know that an upper endoscopy and a 24-hour pH study with an elevated Demeester score are what get the patient into the surgical pipeline to begin with.
Exactly.
Let's talk about the data that actually dictates the architecture of the wrap. The real battleground seems to be the high-resolution manometry.
Absolutely. The pH test justifies the intervention, but the high-resolution manometry, or HRM, it dictates the execution.
What are we looking for specifically?
You are looking closely at the Chicago classification metrics. You need to know the distal contractile integral, the DCI.
Okay.
You're assessing the vigor of the smooth muscle contraction. If the HRM shows normal, strong motility, say a DCI well above 1,000, you generally have the green light for a Nissen.
Assuming the other clinical factors align.
Right.
But what if they meet the criteria for ineffective esophageal motility? Let's say their DCI is hovering around 300 or 400, or more than 50% of their swallows are weak or failed.
That is the hard stop for a complete wrap.
Really? A complete hard stop?
Yes. If the HRM shows ineffective esophageal motility, or IEM, the Nissen becomes a massive liability. The patient simply does not have the muscular vigor to push food through a 360-degree valve.
Wow. So what do you do?
In those cases, you must pivot to the toupet to prevent severe postoperative dysphagia. Manometry is the objective tiebreaker here.
I want to challenge another piece of the standard preoperative workup mentioned in the sources, though, the barium swallow.
Okay, let's hear it.
In this modern era of high-resolution manometry and, endoflip technology, I know some younger surgeons view the barium swallow as an outdated legacy test.
It's true, some do.
So why do these clinical guidelines still mandate an upper GI series before choosing a wrap? If the manometry tells us the pump strength, what is the contrast study actually adding to the decision?
Well, it is a fair critique, but the barium swallow provides crucial dynamic anatomical mapping that manometry completely misses.
Oh, how so?
Manometry gives you pressure, but the barium swallow gives you gravity and structure. It shows you the true functional size of the hiatal hernia in real time.
Which probably looks very different than it does on an insufflated static endoscopy.
Exactly. Endoscopy distorts things with air. More importantly, the barium swallow helps assess esophageal shortening and true esophageal clearance.
Right.
You get to see how well gravity and peristalsis work together to empty a liquid or pill bolus from the esophagus.
So if you see poor clearance of the contrast column on a barium swallow,
even if the manometry numbers look borderline acceptable,
that's a red flag.
That is a massive red flag that a 360-degree wrap might cause significant stasis and dysphagia.
That makes a lot of sense. The manometry is the electrical and pressure reading, but the barium swallow is the actual plumbing test.
That's exactly right.
But let's step into the gray area, because this is where the art of surgery takes over from the raw data. What happens when the physiology is completely equivocal?
The borderline cases.
Yeah. Imagine you were looking at the HRM, and the Chicago classification metrics are borderline. The DCI is maybe 800. It doesn't strictly disqualify a Nissen on paper.
Okay.
But when you take a detailed clinical history, the patient complains of borderline dysphagia. They tell you food gets stuck occasionally, or they have to drink a lot of water to clear a heavy meal.
Right.
The numbers say maybe, but the patient's subjective experience says, I'm already struggling. How do you synthesize that conflict?
That equivocal space is perhaps the most challenging aspect of foregut surgery. Older surgical trials have consistently shown that manometry alone does not perfectly predict postoperative dysphagia.
Wow, really?
Yeah, you can have a patient with seemingly adequate manometry who still struggles profoundly with a full wrap. This is why the patient's clinical presentation, those borderline subjective swallowing complaints, must be weighed incredibly heavily.
Arguably more heavily than a borderline DCI score.
In many cases, yes.
Which brings us directly into the ultimate clinical trade-off, the quality of life equation. As a surgeon, you're constantly trying to balance maximum absolute acid control on one side against the risk of creating new, highly disruptive iatrogenic symptoms on the other.
And we really need to be clear about how disruptive those iatrogenic symptoms can be.
Yeah, what are we talking about here?
Because the Nissen is a 360-degree mechanical barrier, it carries an inherently higher risk of gas bloat syndrome. You're constructing a tight one-way valve.
So they can't burp.
Consequently, the patient often loses the ability to vent gastric air entirely. They lose the ability to belch, and they frequently lose the ability to vomit if they contract gastroenteritis or food poisoning.
Oh, man.
Combine that with a much higher risk of postoperative dysphagia, particularly in patients who are highly sensitive to outflow resistance, and you can create a very unhappy patient.
Yeah, reading through the literature on these clinical trade-offs, a major theme becomes obvious. A perfect reflux cure is a total failure if the patient is miserable every single time they sit down for dinner with their family.
Absolutely.
If they are living in fear of eating bread or meat, you haven't really improved their life. You've just traded the misery of heartburn for the misery of dysphagia and severe bloating.
Yes.
So it seems it is often better to use a slightly less powerful wrap, the toupet, because preserving a patient's ability to eat comfortably is just as vital as stopping their acid.
That is the core philosophy driving the modern shift toward partial wraps. A slightly less robotic barrier is infinitely preferable to a patient who can no longer eat or socialize comfortably.
Makes total sense.
This is why the toupet is so commonly preferred in contemporary practice. And not just for patients with frank ineffective esophageal motility, but for anyone with weak peristaltic reserve or any degree of preoperative dysphagia.
The functional mechanics of it just make it so much more forgiving.
Exactly. Because it leaves that anterior wall free, it allows a weaker esophagus to still clear a solid bolus.
Right.
Furthermore, it often allows the stomach to vent air more naturally, which drastically reduces the incidence of severe gas bloat syndrome.
Right.
The patient maintains a much more natural gastrointestinal function while still achieving excellent mucosal healing and symptom relief from the GERD.
But we should be careful not to swing the pendulum entirely in the opposite direction. I mean, we aren't saying the Nissen is obsolete.
Oh, absolutely not.
Yeah.
A carefully constructed, tension-free Nissen over a large bougie, say a 56 or 60 French in the appropriately selected patient, remains a phenomenal operation.
Right.
It provides unparalleled, durable reflux control for those severe volume regurgitators. It should not be abandoned simply because the toupet is easier on swallowing.
It merely requires stringent patient selection.
Exactly. Good esophageal peristalsis, a symptom profile dominated strictly by regurgitation or acid exposure rather than swallowing complaints.
And an informed patient.
Yes, an informed patient who has an acceptable tolerance for potential gas bloat risks.
So let's distill all of this complex physiology and surgical architecture down into a practical decision rule. For the surgeon listening right now, looking over tomorrow's or our schedule, what is the ultimate takeaway from the modern evidence?
Tailor the wrap to the specific physiology rather than forcing the patient to adapt to your preferred operation.
Okay, so what's the operative rule?
The rule is this. Go with a Nissen when you have strong, objectively proven motility, classic severe reflux or volume regurgitation, minimal to zero preoperative dysphagia, and a clinical need for the maximal possible structural barrier.
Like in a massive perisophageal hernia repair.
Exactly.
Strong river, strong dam.
That's exactly right. Conversely, you pivot to the Toupet for any impaired motility, any history of preoperative dysphagia, or when your paramount priority is lowering postoperative swallowing complications.
And this is particularly crucial in functional benign foregut surgery, right?
Very crucial, because the quality of the symptoms after the operation dictates the success of the intervention just as much as the acid suppression itself.
Right.
If the preoperative physiology is even slightly equivocal, the prevailing wisdom today leans toward the Toupet, as it preserves function while still delivering solid, long-term reflux control.
It is such a fascinating balancing act between engineering and biology. You aren't just adjusting the plumbing, you are dictating the patient's entire lived experience and relationship with food after they leave the hospital.
It is a profound responsibility. And before we conclude, this discussion raises an important, somewhat provocative clinical question that I think every foregut surgeon has to grapple with during the consent process.
Oh, I love these edge cases. What is the scenario?
Well, we established that manometry alone doesn't perfectly predict postoperative dysphagia, and we know physical metrics aren't the entire story.
Right, the subjective experience matters.
So, how much weight should a surgeon give to a patient's purely psychological fear of surgical side effects?
Interesting.
Imagine a patient with perfectly normal motility. Their Chicago classification metrics are flawless. The DCI is 2,500. The river is raging.
And mechanically, a Nissen would be the perfect operation to cure their severe GERD.
Perfect on paper. But during the consultation, the patient expresses profound, almost pathological anxiety about gas bloat syndrome. Or they're absolutely terrified by the prospect of permanently losing the ability to vomit.
Oh, wow.
Does that purely psychological fear justify intentionally undertreating the valve? Do you step down to a Toupet, choosing a less robust barrier against your own physiological data simply to protect the patient's psychological peace of mind?
Wow. That is an incredibly heavy question to mull over, because as a surgeon, you are trained to follow the objective data. Letting a patient's preoperative anxiety dictate the surgical architecture feels counterintuitive when the manometry is basically screaming for a full wrap.
Right. It feels wrong objectively.
But at the same time, if the ultimate metric of surgical success is their overall quality of life, perhaps a severe psychological aversion to gas bloat is just as real and debilitating as a weak peristaltic wave.
That's the argument.
I mean, you might cure their reflux with a Nissen, but if they spend every day obsessing over trapped gas, have you really healed them?
It perfectly illustrates the ultimate intersection of objective clinical science and subjective human experience in the operating room.
Yeah.
The data can only guide you to the door. The art of medicine dictates how you walk through it.
Well said. To all the surgeons and medical professionals listening, we hope this deep dive into the nuances of wrap selection has provided some valuable framing for your next clinical consultation.
It's certainly a lot to think about.
It really is. And if you like this content and found it useful for your practice, please do not forget to share this session with at least one of your colleagues or friends. Spread the word. It truly helps us out.
Definitely.
Also, make sure to check out our YouTube and other social media pages for visual breakdowns of these concepts. And definitely go back and check out our previous season and episodes. We cover some very relevant foregut, surgical, and complex medical topics that you will definitely want to add to your rotation.
The landscape of foregut surgery is constantly evolving, and refining our approach to patient selection is how we push the field forward.
Absolutely. So the next time you are analyzing a borderline high-resolution manometry study, just remember the river and the dam. You can build the most robust structural wall in the world to stop the acid, but if the water can't flow downstream, you haven't really solved the patient's problem. Thank you for joining us, and we will see you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.